Good afternoon. Welcome to the Institute for Healthcare Policy and Innovation's annual Director's Lecture. I'm John Ayanian, the Director of IHPI, and I'm very pleased and honored to welcome our guest speaker, Dr. Eliseo Pérez-Stable, the Director of the National Institute on Minority Health and Health Disparities. Dr. Pérez-Stable has served in this role since 2015. His institute is the lead institute at NIH for advancing the science of minority health and health disparities research, including mechanisms to improve minority health and interventions to reduce health disparities in the community and clinical. NIMHD also promotes diversity in the biomedical workforce, supports research capacity at less resourced institutions that train underrepresented students and serve populations with health disparities. And the Institute supports inclusive participation in clinical research. Throughout the COVID-19 pandemic, Dr. Pérez-Stable positioned NIMHD at the forefront of the research response to COVID-19 health disparities, and he co-chaired 3 major new NIH-wide research programs in collaboration with other NIH institutes and centers. Prior to becoming NIMHD director, he had a distinguished career in academic medicine as professor of medicine and chief of the Division of General Internal Medicine at the University of California, San Francisco, or UCSF. He's a recognized leader in Latino healthcare and disparities research. He's done groundbreaking work on smoking cessation, tobacco policies, and cancer control in the US and Latin America. He's published over 300 peer-reviewed papers and been a research mentor for over 70 minority investigators. Dr. Pérez-Stable has been elected to the National Academy of Medicine and the American Society for Clinical Investigation. He earned his BA and MD degrees from the University of Miami and then completed his primary care residency and research fellowship training at UCSF before joining the faculty there. Please join me in welcoming Dr. Pérez-Stable. So Eliseo, to start us off, can you tell us a little bit about your background and what brought you to this leadership role at the National Institute on Minority Health and Health Disparities?
So, first of all, thank you, John, for the gracious introduction and the invitation. And it's great to be here and have a day where I'm not just up there showing slides and lecturing, but really having interactions and talking with all of you about the things that you want to know about. So I was born in Cuba. I left as a consequence of the Cuban Revolution. My parents sent me out with my older sister and my grandparents, and then about a year later they followed. I spent time in Miami. I spent 6 years in Pittsburgh where I learned English, and then back to Miami for high school, college, and school. I matched in the UC San Francisco program, which was not what I expected. And San Francisco is home now more than anywhere else in the world for me and my family. What led me to want to leave, I will say it, the most beautiful city in the country, just a wonderfully diverse and unique setting. And wonderful institution in many ways, really was the interest in advancing the science on minority health and health disparities and having impact. I ended up at NIMHD because John Ruffin retired and the job was available. That's one thing. I had known NIH mostly through having been on the advisory council for the National Institute on Aging, and spent 4 years sort of seeing how they worked and seeing sort of NIH from the inside, seeing the dedication, the passion, the intellectual rigor, perhaps being fortunate that I was in an institute that has a broad spectrum of research, so where my work would fit in very well in their behavioral and social science research division as well as their clinical gerontology division. But overall, that was, I think, a real impactful time. So when the opening became available, I was ready to say, okay, I'll apply. And then it has not been something I've regretted for one second. There were challenges, like anything you do, but certainly giving up patient care, which for me was a very big deal, although at that stage of my career was, possible to do, really has been a very rewarding experience in being at NIH. So.
Great, thanks. So I also want to welcome our live stream audience. I know we have well over 100 colleagues signed on to join us on the live stream, as well as everyone here. Some of our audience may not be as familiar as others with NIMHD as an institute. And I wonder if you could just tell us what the role of the institute is and how it's changed or evolved over time.
Yeah. So NIMHD started as an office director. Secretary Sullivan asked NIH to do this in 1990 or so. Some may know the so-called Heckler Report, which was a report on the status of minority health in the U.S. from the Health and Human Services Secretary Margaret Heckler, under the Reagan administration, by the way. And Dr. Sullivan had been instrumental in that happen as a individual faculty at Morehouse. And I had that. I still have that report in my bookshelf at the office. And so the 1990, when the Office of Minority Health Affairs and then Minority Health Research was established in the Office of the Director, and throughout the 90s it was there. Legislation championed by Congressman John Stokes in the year 2000 led to the founding of the Center on Minority Health and Health Disparities. And then we were elevated to an institute in 2010. Now, mind you, all this had, there were barriers on the way. The NIH directors of the time were not necessarily in favor of any of this. But I'm reminded that almost all institutes were founded through some sort of legislative action, and there wasn't always a moment of when everyone said, oh yeah, that's the right thing to do. So that's in the past history. And certainly central to the mission of our institute is to look at, monitor, and do strategic planning on minority health and health disparities for the agency. So I have that responsibility as the director of the institute, and has been made very clear to me by our new NIH director, Dr. Molly, that she wants the director of NIMHB to be the voice for NIH as a whole on all issues related to minority health and health disparities. So we are charged, through statute to monitor and provide advice to the institutes on what topics are being covered. We look at how much funding is being spent by overall and by each institute on the science of minority health disparities. And we now have created a system by which that can be done with reasonable accuracy and without tedious manual coding, which was what we used to do. And so then there's a category of capacity building, which is important, and the category of diversity of the workforce, which is also important, that can be separated out through this automated algorithm of what's funded in NIH. And so in that role, you work with your colleagues, and it is a collaborative role. You just don't march in and say, I'm the boss, you're going to do what I say. Because the NIH director doesn't do that either. But we create a collaborative environment. We ask people. We know what and how much to ask, how intensely to do it, depending on the issue. And we try to move forward with that. So.
Great, thanks. So in December, you and your deputy director, Monica Webb-Hooper, published a viewpoint in JAMA Health Forum describing race, ethnicity, socioeconomic status as the pillars of disparities science. What are some of the key points that you raised in that viewpoint and that you communicated to the broader audience of clinicians, researchers, policymakers in the United States?
And linked to that is other analyses that have been published under either directly from us or the investigators that we fund. So this crude social construct of identity that we call race and ethnicity, that I've spent the bulk of my research career thinking about, it just predicts so much in health outcomes that we don't understand how, that it makes it sort of essential that we measure it and consider it in everything that we do, both in service, clinical service and research, and do it in a standardized way. Doesn't mean it's always going to matter. It doesn't mean it's always the most important factor. But we've got to look at it and consider it. And there's still a large community of clinician investigators who don't. They may measure it just to comply with some advice and regulations, but they don't really think about how it might impact outcomes. The other pillar, as we call it, is socioeconomic status or social class. We've known probably for centuries, and observations made by many other civilizations, that if you're poor and disadvantaged, you will do worse than if you're not. Now, it doesn't always work that way. It doesn't mean that, if you're poor, you're always going to do worse, because I think that's the assumption people make, and that's not necessarily the case. And of course, those of us here may not know or remember, but back in another era, to actually be in excess weight was a sign of wealth, because you had plenty of disposable income to buy extra food. And of course, now we know that's gone the other way. So we see those as two critical constructs that drive not all inequities, but a lot of the inequities that we observe in health, and then intersect with every other demographic factor and condition. There are populations that are designated as having health disparities. Some of it is through the legislative process, with rural populations were included in our original legislation as part of the building bipartisan support for the legislation in the year 2000. And it's a good thing, because people who live in rural areas have specific issues that often people in urban areas don't have. And that's been a lot in the literature about how we need to consider that, depending on how rural one is. But clearly no one would disagree that it has to do with socioeconomic status and race and ethnicity in the rural area, and so on. With sexual and gender minorities, the factor of, first of all, identifying, recognizing, and evaluating and studying what are the health issues that exist outside of the HIV sector. This is the history of the populations. And then most recently with people with disabilities. Having a disability, in sort of my way of thinking as a clinician, I was thinking of it as a condition. And so when do we stop, when do we start naming any condition, any chronic condition will have worse outcomes? So if you have diabetes, you'll have worse outcomes. So where is there a line? People with disabilities have an identity as having a disability, particularly people who have a physical disability. Other groups, with neurodiverse and people who are autistic, or whatever the condition is. It's 25% of the U.S., per the CDC, identifies having a disability. And so that is now a designated population. There are 6 institutes that have major investments in this area. So where is NMHD going to add to this? And we put out a funding announcement to look at this. We consider certain groups, individuals who have physical and cognitive disabilities as children and grow into adulthood, because we're much better at taking care of them, and they can kind of get lost when they become adults in terms of who looks at their issues. And then also, I think people with post-traumatic, either brain injury or violence or a firearm or motor vehicle accidents, who lose function, paralysis, lose a limb, and they frequently have, again, limitations in many things in health care. That's why I think a lot of the issues with disabilities are underlying is in health care as well as in society. And so, and then we again see this unifying factor of discrimination. and racism as a unifying factor. All these populations have been victims of discrimination. We don't have to go over that again in terms of efforts to consider them inferior, extermination, structurally create barriers. All these things have happened in our history and in the global history. So I think for all those reasons. But the main point of that commentary was really to focus on mechanisms, what drives from the scientific perspective, and was not in any way meant to say other things don't matter. If you have Down syndrome or you have congenital heart disease, that's going to drive most of the variance of your health outcomes. And what we're saying is if you have this condition and are poor, or come from a family where no one went to college, your risks and likelihood of worse outcomes are going to be greater than someone who doesn't have those factors. So.
Thanks. So in the last few years, our field and we as a research community have started paying closer attention to structural factors that drive health outcomes, including structural racism. How do you think researchers, policymakers, community leaders should be thinking about those structural factors and sort of the role of NIMHD and NIH more broadly in addressing those structural factors beyond many of the individual factors that much of the research community is focused on for decades?
No, that's a great topic to discuss. We have a research framework that I trust many of you have seen, and in the column that says individual is where still the majority of our grants are funded. So it's hard to do the structural. It's hard to do societal. Maybe with an ROI, much more resources to do things like that. But I think that we have to keep driving that toward the field towards doing more community-based, community-engaged, what are the interpersonal dynamics, and not just think about individual factors. In thinking about structural issues, a lot of times we start with, the place we live, work, play, and worship. And so it has to do with housing, has to do with transportation, access to food, public safety, and relationships with the authorities. And these are some of the things that people think about. And if we've marginalized the community against all those potential benefits, and they have no ability to access those, what chance do they have of having good health? So much lower chances. If you go back into the history of all of this, that's where it gets most challenging, and that's where you see the societal responsibility here. People are tuned or aware of what the residential segregation was about, the history of redlining in our country that was actually implemented during a very progressive administration of President Roosevelt, where banks were uninclined to loan money to areas that were deemed to be undesirable. And those were the parts of cities that were populated primarily by the Negro population. And then World War II ended, and the United States went through a major economic boom, access to loans, equity, buy houses, and black people in this country were excluded from that. And Latinos were as well. It just followed about 10 years as the Latino population, primarily the Puerto Rican population in the Northeast and the Mexican-American population in the Southwest. And as my colleagues in this field taught me years ago, it's like, you play Monopoly, and there's a group of people playing, and then you say, okay, you're not going to start yet. You wait, and wait for an hour or so, and now we got some hotels or houses and a bunch of properties. Now you can come and play. And of course, you never can catch up. You're just paying rent all the time, right? And I think we have a responsibility. Now, what things are optimistic? What are my thoughts on that? So there's a lot of interest in how we can create healthy communities. Can we take what we have, the assets that exist, and find ways to have a neighborhood, a community, be healthier? So by addressing things like that people really care about. Being able to move from one place to the other in a reasonable amount of time, being able to buy affordable food, having housing that they can afford and is in decent shape, not necessarily own, but just afford to live there, having access to green space. All these things are doable. And I think we need to do more of that kind of work, demonstrating that that's going to lead to better health outcomes than what we have done. Linked to that, I think it may be more manageable for us in academic health centers, is having better health care and having healthcare quality and access that's available and provides equitable care. Again, that's doable, and we have an infrastructure that can lead to that, the FQHC, the community clinics, and there are many other, practices, or especially through academic health centers or public hospitals, that provide the infrastructure for that. It's not just about the community, because people in the community do get sick, and people in the community age and develop chronic disease. And when you develop chronic disease, you need health care. And when you're healthy and younger, you may be, health care, you don't really need doctors. But as you develop, you need chronic medication, then you're going to need. One thing that I think, retrospectively, looking at what happened in the U.S. in the 60s and 70s, is how the movement to integrate, quote unquote integrate, meaning black, white, living in the same community through schools, through other mechanisms, was actually beginning to work when we shut it down. We shut it down for political reasons, had to do with busing, and it was around 1980. And you look at the health measures for African Americans in the U.S., we didn't have really good measures for Latinos, and they're different in other ways. And they were consistently getting better until 1980, and then things started getting worse again, until towards 2000, when you started seeing improvements. And there's other evidence that mixed communities, not necessarily by race and ethnicity, actually are healthier communities. And yet we don't see that too often. When some big cities, you get neighborhoods like that, but it's really not by design. And by mix, I mean, wealthy people are never going to live with the rest of us, right? I mean, they're in their own world. It's just the reality. And if you put a whole bunch of people who are socially disadvantaged in a big area together, and you have no resources, things are definitely going to not go well. And we have communities like that in all our big cities in the U.S. But I'm referring to, there are poor people, there are working people, there are middle-class people, there are professionals, there's businesses, there are small businesses. And creating the mechanisms to then provide access to healthy food, having green space, these are things that over time, I think, will lead to change. These are structural and doesn't depend on, you've got to behave better. You don't use those drugs. Or eat better. What's wrong with you? Why don't you, rather than do this, do that? And individual behavior change is important. Don't get me wrong. But look at the tobacco world. We've done a lot. The best cessation interventions in tobacco, 40% cessation in 6 months. But if you put in structural change, things change. And so when we prohibited indoor smoking, all of a sudden, stop smoking, or they smoke less, and that is also harm reduction is important there. Or when you tax it, you saw improvement, and you reinvest the tax money into ways to decrease smoking. So I think those are all structural interventions that could be leveraged depending on circumstances.
So in the last few minutes, you've mentioned community at multiple points, and much of the work that NIMHD funds requires effective partnerships with communities and people who live in those communities. How do researchers sort of establish trust, and is there guidance from research that NIMHD has funded, or kind of other things we've learned about how folks in our academic community can develop those effective partnerships to address some of the issues that you just discussed?
Right. No, I I think we're at a good time to really push this further forward because of the pandemic. Community engagement and broadly speaking, with a particular method or approach, I think there are many ways to get at this. Has been acknowledged at NIH as being an important research platform. So it was always about being nice. Okay, yeah, we got the community there. Let's be nice to them. You know, we'll have an advisory board, and you know, this is about, if we're going to move the needle, if we want to advance the science, we've got to go get in there and work in the community. And that pandemic made that happen because, you know, people realized that, you know, this was a crisis. And when the clinical trial for Moderna, which was happening with government support, and all of their volunteers were white, you know, Francis Collins said, you know, this can't happen. So we worked with them. Yeah, they eventually did a really good job of having a population that looked like America. You know, we didn't expect the vaccine would have differential impact by race and ethnicity, but how could we tell anybody with a straight face if the sample was not diverse? So that was a critical point, and we had leverage because there was $1 billion that they had gotten from the government to do this. But that got us started with the Community Engagement Alliance, SEAL initiative, which Michigan has a team, and partnering with Gary Gibbons, the National Heart, Lung, Blood Institute. And it really starts at, I think, the point, and we've talked about this at the NIH directors level, because we're ready to do more. Now, COVID is mostly in our rearview mirror, not entirely, but we're ready to move on to other topics with SEAL, with our infrastructure. So we're supporting an infrastructure that supports academic community partnerships that will focus on an issue. Initially it was COVID and participating in clinical trials for COVID and vaccination. Now we're shifting to other topics, primarily around issues around social determinants of health and prevention of chronic disease. We're in that transition, so it can't be much more specific than that. And the 21 teams that are funded have been in states and areas where the pandemic had been disproportionately impacting minority populations. So we can't do everything for everyone with SEAL. But the principles are the same. So the investigators, you need to go to the community. You can't pretend to ever like send your research assistant or, oh, I don't look like the community, so I can't go there. Wrong. You gotta roll up your sleeves and go down and, you know, ask for a meeting, meet with their leadership. Meet with one organization, meet with one person to begin with. How do you get started? That's how you build trust, by building a relationship. You don't go there and say, I've got a project for you. That's the wrong way to go. And unfortunately, for many of us in academics and many researchers, you know, you've got a grant, you've got a timeline, you've got to do this, you've got to do that, and you don't have the luxury of, okay, let me build this relationship. So this is not easy, and then early career people will get, you can't do that because you have to publish papers, you have to get a grant, and you're wasting time doing that community work. It's not going to lead to good research, and so forth. It was always been deemed as soft research, not rigorous. But and you can debate about that, you know, and how you do methods and implementation and outcomes. There are ways to heighten the rigor to a much higher standard, which I think is, you know, you can create causal inference from these kind of research. So I think the investment in infrastructure is key. We hope that we're committed, I should say. Gary Gibbons and I are committed to doing this with SEAL. We hope that other institutes might do something like this. The HEAL initiative is one great example of where this has gone on, although that's probably not feasible to continue at the level it is now. But, you know, can NIDA and other ICs maintain some sort of community partnership to address the overdose epidemic that this country is living through now more than 10 years? And so I think that the building trust, shared governance, making sure that the questions that are being asked mean something to the community. And I can think most of the time you can get your issues in there. It's just a matter of not making it like I'm telling you what we want to do, and then continue to have a relationship. Having community boards is great if they're meaningful. So people come in and give you advice, and real advice. In the SEAL initiative, we created a rule that at least 25% of the funding for each of the teams had to go to the community organizations. The Compass initiative, that the Common Fund initiative just launched, went a step further. We are directly funding 25 community organizations to address structural issues in inequities. Where have these proposals come? They fell into housing, economic opportunities, transportation, food was a big one, and healthcare. So those are the ones I remember. And there are going to be, they had to have an academic partner, and they had to have, and there will be these academic hubs, which I think have yet to be funded to support the Compass initiative.
So I want to shift gears to a fairly hot topic of artificial intelligence, which is just growing every week and month in terms of its focus broadly in society, but specifically in healthcare. And we know from some early research on health-related topics that AI algorithms can be trained on biased or incomplete data and sometimes lead us to inaccurate or wrong conclusions in how we allocate resources and provide care. How is your institute and the NIH more broadly thinking about the integration of AI into research, and particularly with a disparities and equity lens? Sort of what can the research community be doing to make sure that we use artificial intelligence fairly and justly and not perpetuate the inequities that have already developed in society?
This is one area, John, I would not be considered nearly anything close to an expert as it came more recently. But there are things going on. First, it starts with who's doing the work. And I really think that data science is an area that we need more capacity in, with a disparities lens and more diversity in. It's predominantly males, the scientists in data science, white and certain groups of Asians, and very, very few other race and ethnic groups represented in the scientific, and much fewer women than, for example, in NMHD, where we have more women investigators than men. So it starts there, and you say, well, is that really the main issue? Well, they frame the questions, they create the environment, they do the team science. Yeah, it's important. And you mentioned this idea of if you have garbage in, garbage out, right? So if the data are biased to begin with, then the machine learning, it'll only spew out what's in the data. So we need better data. Now, last week I said, one of my mantras when I give a talk is say, we need standardized measures of the things that we're going to do. And we need to do them the same way across the field, and in survey research, every scientist wanted to ask the question a little different because they don't like that phrasing, they like that phrasing. It starts with race and ethnicity and some measure of social class, and so on and so on. And he thought, well, what if you just get imperfect data, but you have so much of it that machine learning can figure it out? So I don't know. I didn't know how to answer that. But you gotta, and we're still not there. I mean, people aren't doing this. They're not doing it in, we talked earlier about, how is Medicare doing it? How is the private insurers doing it for health services? How does the clinical system do it for the electronic health record? We know how to do it because people have studied this. We know how to ask about race and ethnicity. We know how to ask about educational attainment. We know how to ask about language fluency. We know how to ask about sexual orientation and gender identity or disability status, but I don't think that we can point to any system that does a great job doing this. In healthcare, now it's been a while since I've been in the weeds with healthcare, so I may have changed. But I don't think that that's the case. We don't do it at the NIH Clinical Center. I can guarantee you that. We're trying to get them to do something along these lines. And then the last thing. So what is NIH? What are we doing about it? You know, we're really at an infancy stage. We do have a data scientist we did bring onto staff late last year. We have one of our scientific senior people who decided that she was going to focus on this and has really moved areas along. So to create a cloud-based system that could function as a data repository if people collect data the same way on social determinants, doing a lot of these monthly seminars, webinars called Thinkathons, where her perspective was, well, our community of scientists feels so out of the data science world, out of the AI, everything, that they don't know anything about the language, and they go to a lecture and they get lost in the first 5 minutes and they give up. And so her idea is start with just really basic stuff, you know, like 101, this is this, this is that, and they've had 100, 200 people every month sign on to these webinars. The NIH invested, I'm not going to remember the dollar amount, but it was somewhere around that $50 million into this Aim Ahead initiative. It is being managed out of the Office of the Director in the Office of Data Science Strategies. And they have, I think, made good progress in what they're doing. They're trying to do all these things with a equity, disparities lens. So, for example, create a way to abstract electronic health records from systems that have them into a common repository where they would be available for analysis. In the case I'm thinking about, networks of FQHCs, for example.
Federally qualified health centers.
Federally qualified health centers, like community clinics, although most of them are federally qualified. Which means that they are able to charge more for Medicaid patients, or get paid more for Medicaid. They don't charge; they get paid more for Medicaid patients, and train more people in this area, and covering the spectrum of American Indian, Alaska Native that have the big challenge of governance, sovereign nations, and data sharing. And it's an issue that is really important to address up front. That NIH has messed up more than once. A place like Howard has capacity to do more computational capacity and informatics, and they've been at the forefront here as well. So it's like an area that I don't know enough about to have strong opinions. I just know that we need people and we need to do more.
Okay. So we had some questions submitted in advance by our attendees, and I want to pose one of those to you and then open it up. We have roving mics and an opportunity for those of you here with us in the audience, and I don't know if we have a connection to the live stream for questions to be posed there. But the question that was submitted in advance, one of those questions was, what interventions focused on social determinants of health are you most excited about?
I don't know what I'm most excited about until I see the result. But I mentioned earlier, I think if you think about housing, that's a potential one. So where people live depends so much. And if there's cite the Moving Opportunity study from HUD, which showed that if people were given a voucher to rent in another community besides the one that they were destined to be renting in, low income. This was 6 cities. Individuals were rented mostly. In fact, I think it were only single mom households. That their BMI and metabolic measures of diabetes and hemoglobin A1C were better X number of years later. I don't remember the details. This was New England Journal a number of years ago. It was not designed as a health study. HUD did this sort of as their own sort of innovation. And NIH found out about it and said, we'll fund an evaluation. We'll add this, we'll add that. And other departments did as well. So if we figure out how, this is getting back to the idea of mixed communities, being healthier. Communities have gotten more tuned in, and this is urban communities primarily, as well as, micro-urban, not necessarily what the rural world needs. Attention to these issues of where can I get healthy food? It's remarkable, you go to the supermarket and exit to pay, or now it's self-pay, but there's like a wall of junk waiting, inviting you to pick up that extra something, and this ultra-processed food and that we increasing evidence how that contributes to what we're experiencing, not just in excess weight, but also with metabolic issues and probably cancer. And so I think that changing that is going to be a big. So one thing I saw, I live in the District of Columbia, and there's a farmers market 5 blocks from where we live. And so on Saturdays we go to the farmers market, and there are people there with their SNAP vouchers buying fruits and vegetables. Now, that's a individually structural change, right? Mm-hmm. So, or making healthier food affordable. Mm-hmm. So they say, well, for $5 I can get, not be hungry. But if you buy $5 worth of fresh fruits and vegetables, some of them will go bad, and you have to cook, so I think that we need to get at some of those factors. The other is healthcare, as I mentioned earlier. I think those are the ones I would, food and housing. Economic opportunity, obviously, although we have less of a leverage on that. But I think that has to happen in parallel, societally wise, and then, nurture it. And I think the model is, what's the right mix of small businesses and, dominant corporations? And clearly it's a healthier market if there are many more small businesses to a large extent. So that's a balance. That's beyond my ability to decide, but I think we need that at the table. And then there's all this issue with climate going on, which is more complicated. So
I think we have a question from Ken Resnicow. And Ken, there's a mic coming so the live stream audience can hear your question as well.
Because of a slight back problem. Is this on?
Yeah.
So I'm going to, 3 quick questions, too. I think you've heard
Maybe
from me
just
many
hold
times.
the mic a little. Yeah, that's better.
What are your thoughts on designating the MENA population as a ethnic racial group and eventually progressing to a population that experiences disparities and all that entails? What are your thoughts about more focused research on multiracial and biracial? It's one of the largest groups, and they have very interesting patterns, but we don't do a lot on that one. And now, a combination of a question and praise. I've seen you in action now for many years, and I notice an attribute you have, and I'd like your comment on it. When I train emerging investigators in the disparity space, I usually discourage them from saying things like, the rate of this disease is X in whites, and sadly, it's this in blacks, and they editorialize. I've noticed, I think I've seen you speak maybe 25, 30, 40 times. You seem to be very careful to take out editorial adjectives. And I'm just curious if that's an intentional strategy, or is it just like your natural thing? But you do it very well, and I think it's one of the reasons you survived a lot of minefields in the world you swim. So is that something you were trying to do?
So thank you, Ken. I didn't set him up for this. Ken was a member of our advisory council for 4 years, so we got to work together quite a bit. So the Middle Eastern North African identity as a separate ethnic group was proposed previously in 2016. It was not put forth by the Trump administration for reasons that were never explained. The executive doesn't have to give explanations. They did make one change in the census for 2020, which was that people who identified as white or black, African American, were given the option to write in their national heritage background. That's the first time we collected data. I haven't seen any analysis of that, but that was done in 2020. All the other groups already did that. So the proposal has resurfaced. This administration is very supportive. I thought they wanted to get it done this year, before November, but I don't know where it's at. It was cleared by the usual government processes, which means the departments get to see it. We were given a briefing about it, both as director of NMHD and related to the Disparities Council within the Department Office of Minority Health. And they're very detailed rationalization or discussion as to everything that they were proposing, that they were changing and not changing. You know, it's moving the right direction, in my opinion. They're eliminating the two-part question about race and ethnicity. So I think it'll be better. But I want to see it done sooner rather than later. The multi-ethnic, multiracial identity there's a complexity to that because the census algorithm has been confusing. Let's put it that way. So, you know, the first two census where that was an option, it was 3% and then 2.5%. So the reality says, well, that can't be right. People are more mixed. So how can it go down? And then in 2020, it was 10.5%. And what they did in 2020 was that if you checked, if you were Hispanic or Latino and you checked a race, then you were automatically put into the multiracial. And so I guess I'm multiracial because I checked myself, Hispanic and white. So the Hispanics, Latinos make up 70% of people who are considered multi-ethnic. So I didn't get at the same question, I think, so who has an identity as multi-ethnic? And I think that's, now the health of people who say they're multiracial, and this is from CDC, so I presume they didn't do that algorithm. There are concerns in some of this, signals that raise issues, riskier sexual behavior, more substance use, worse self-assessed health, and these are from either National Health Interview Survey or Behavioral Risk Factor Survey. So again, we don't know enough yet to say with certainty, but is the mixed identity creating new challenges because of problems from both sides or three sides, or is it a strength? As other indicators might indicate, you have more diversity, you get, Then on the issue of comparison, I hadn't caught that, so thank you for that comment. I think it comes more from my trying to be scientific on things and not advocate. But one thing we are doing, I think you heard this before, was to get away from comparisons to whites all the time. And we did that with the equity, the economic cost of health disparities paper we published last year through Darryl Gaskin and Tom Levy's analysis, a contract that we provided. And I'm trying to get the Global Burden of Disease Institute for Health Metric Evaluation to also change what they do with that. And I think we're making, they've agreed, we provide the money, so they'll listen. But it's also an intellectual and an academic thing. So why are we comparing to one group all the time? Whites don't always have the best outcomes, number one. Number two is white Americans are not going to be in the majority if demographic trends continue past 2040. And then there's this whole mixture. I'm white, but my identity is Latino, and so where do I count? Many people from Middle Eastern, North African background are also white in terms of, if you think about the origins, geographic origins of humans. So I think this, on the identity factor, what people do is set national standards and say, like Healthy People 2030 is great. They said the country should be at Blum by 2030, and use that as our comparison point. Now, they don't do that for everything, but they do it for a lot of things. And so I think that's the direction we should move. Or just say, these are the rates, these categories, and not create, multivariate models that use a reference point for whites. And so I think that it's going to be a process. That's my thinking on this now.
Other questions? right in the back, and then one over in the middle. Jason.
I can't help myself if you mentioned there's only so much you can say, but I'm curious about where things are going in interventions, including addressing some of the immediate social needs and larger social determinants of health. You were talking about a shifting towards that kind of science, and I'm curious more to dig in because there's been so much important work done in health disparity science in observational space, and I think many of us are eager in the action space, merging both the intervention and the evaluation of those interventions. So I wonder, to the extent you can, if you could say more about that.
Well, I didn't mean to withhold any information. It's just the limit of my memory. There's multiple things, though. I mean, there's a group of us who kind of know what we're talking about when we say social determinants of health. Mind you, not all agree on everything. For example, I insist that individual factors need to be considered in talking about what we call social determinants of health. Now, we can say demographics on one hand, but they need to be there, right in the front and center. But there are also individual measures that would fall under this, whether it be food security or health literacy. There's another group of more population scientists who say, no, individual measures are not what we're talking about. It's only structural. The CDC wheel of social determinants, the individual is sort of symbolically represented, I guess, in the middle, but they're not mentioned. It's all about structures. And of course, it's easier to measure things in the individual than it has been with structures. And the measures of structures have often been derivatives from the census or the American Community Survey or imputed data that, although good and useful and better than nothing, but they're not quite the same, I think, in my view. So there's that complexity on those of us who are championing this. And then you get confusion. People say poverty is a social determinant of health. I've seen that come through in documents. It might be, the CDC actually puts racism in their definition. I mean, I'm confused. Is racism a social determinant, or it's a product of structural social determinants that led to racism, structural racism or individual racism? So there's a lot of work to be done on, okay, let's agree what the terminology is, how we refer to things, because I think there's a lot of confusion. It's a buzz term now, and it's a big umbrella term, and I'm fine with leaving it at that, but then let's be clear on the specifics of what we're talking about. The other one that gets confused is behaviors. So people are saying behaviors of, like substance use behaviors are categorized in the social determinants of health. So a lot of well-meaning scientists are using the term as this big umbrella term that just all that stuff that isn't biology or physical exam or blood tests, they're calling social determinants or events, I guess, clinical events. And so it can get confusing. There's an RFI, request for information out from the Office of Data Science Strategies on feedback on sort of common data elements. This was required by Congress. One of the ones that they have is on social determinants of health. Check it out, because it's only a request for information. It's not I'll send you the link if you haven't seen it. It's not a decision made already. So we still have time to modify what gets reported back to Congress, hopefully. And so I think that this is a sort of a moving target. If all we're talking about is structures, I think the interventions that we talked about are what we need to focus on. But you need individuals involved as well. So they're not isolated. I don't know if I forgot if you said funding priorities. Oh, funding priorities, yeah. This type of work moving. Well, I think we're always open for innovative research on interventions in community engaged or community settings. We have a standing interest in that. In fact, it's not a set aside, but it's definitely a program announcement. The Compass initiative I mentioned, funding decisions have already been made, that's what, $300 million over 9 years from the common fund. So it's not an institute specific. Yeah, it will create a science, a group that hopefully other institutes will pick up and follow. The SEAL effort is definitely focused on interventions as well. Now that is already defined, but it's we're in Michigan, so it's not out of reach completely, and it is focused on, as I said, social determinants, prevention of chronic disease, and they could benefit from more scientific rigor. Let's put it that way, in my view. I co-chair the program.
Oh, we have time for one more question from the audience.
Hi, I'm Regina Ryan. Thank you for coming. My question was, could you talk a little bit about the Institute's priorities or your thoughts in general about how to increase the diversity of the scientific workforce?
Yeah. So we don't have, the young people in this audience are going to have to help solve this because we failed, right? It's 14% right now of graduates of STEM PhDs in the granted in the U.S., and 14% of medical students are from underrepresented populations. And then, the number inches up a little bit, but it's, very, very gradual improvement. It's worse with principal investigators. You know the story. So what NMHD, what I brought to the Institute, I said, well, people want to do programs in, high school and grade school. And I said, well, what I know how to do best is to help people who make it to a fellowship and nurture them and support them. And that's what we're going to do. And so we have that incorporated into all our centers. They're called investigator development corps. They, of course, are not saying, well, you've got to be of this group to be receiving a grant. But there are investigators with center grants at institutions, often either working with underrepresented groups or, research institutions that will have one of these centers. So that's one structural way to promote it, by giving people money, small amounts of money, $50,000 for 1 or 2 years. Because I saw that work when I was at UCSF. And then, of course, you need mentors who are generous, who don't need to be first author or PIs on everything, and work with early career faculty, researchers, to bring them along. I think there are issues that why we lose so many people. The pipeline's not empty. I guess that's the point. 14% is not 4%. It's not zero. We've got people coming out, and we're not hiring them. We're not supporting them. So, of course, we have to work with high school students and the community and grade school and provide higher levels of science literacy at all levels. But in MHD, this is what we could do best. The other mechanism is the diversity supplements. We will fund almost, when we have any budget, 50, 60% of supplements more that get presented to. But there has to be a principal investigator who has to take it on. And that's, people come, well, I want to apply for diversity, but I can't find anybody. I don't have anybody. Or, a very successful researcher getting their third or fourth R1, not at the same time, but in sequence, and they haven't brought, they're working with Disparities, they're committed to it, and I go, where is your diversity supplement for a scientist? Why haven't you brought someone along? You're working in the community, you're doing great things. Why don't we get a scientist that helps you, you bring along in this? I think that's kind of responsibility that people need to see that as part of their mission. And some researchers are susceptible to that argument and will do it, and others don't care. That's just the reality. They just want to, pursue their science or be successful. But I think the progress is there. I think this is a topic that all institutes are sensitized to. The National Institute of General Medical Sciences has a big portfolio on promoting diversity in the workforce. I think that people in arterial heart, lung, and blood, diabetes, and kidney disease, digestive disease, Genome Institute, NIDA have all made efforts depending on their topic and communities. So,
Eliseo, we're just about at the end of our time. I want to ask one final question. As you look over your term now, approaching 9 years as NIMHD Director, what are you most proud of or sort of most optimistic about looking toward the future?
I'm most proud of putting NIMHD front and center in the NIH conversation, because I think when I got there, NIMHD had been either marginalized or they circled the wagons for whatever reason, and we weren't really sort of at the table. And I think now we are, and it's obviously not my doing by any stretch of the imagination. It's, getting the staff really motivated, getting the community of scientists to send us grants and for us to think of innovative programs. Not everything that we've done has been successful by any stretch of the imagination. I've hit a number of walls here and there, but people, taking to heart what I heard from Monica Bertagnoli, the new NIH director, is I want you to be the voice of NIH on minority health and health disparities. Not NIMHD, the voice of NIH on this. Mm-hmm. And taking that to heart, probably 10 years ago, I don't think Francis Collins would have felt ready to say that because he wasn't sure what I would do. And his prior experience maybe wasn't lending itself to that based on how things had worked out. Incorporating all these importance of social factors into research that speaks to the mainstream has been also an important change, I think, that I've been instrumental in helping create. And now there's a much more receptive group of institute directors on that. As well as, the Nursing Institute is led by population scientists. The Deafness Communication Disorder Institute is led by a head and neck surgeon who is a clinician researcher. Eye Institute is led by an ophthalmologist who does informatics research. So, there's other disciplines that are at the table. It's not just genetics or basic science. In some of these institutes that were more, we didn't really relate to very much. So
great. Well, I want to invite everyone who's here with us in the room to a reception right afterwards outside the auditorium. And Eliseo, thank you for spending your day with us today here at the University of Michigan. And please join me in thanking Dr. Pérez-Stable for speaking. Great.
Hope that, yeah.